Pledge of Allegiance. I pledge
allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Good morning and welcome to the work session of the Shawnee County Board of County Commissioners for this is March 4th, 2024. My name is Kevin Cook, serve as the chair. Joining me today is Commissioner Aaron Mays, Commissioner Bill Rippon.
Good morning.
We have a work session today for Vallejo to give us an update on their behavioral health care. So I'm going to welcome Bill Persinger up to talk to us a little bit about Vallejo and what they've been doing.
Thank you, Chair. Flip this phone off so it doesn't ring during the middle of things here. Well, can't get it out. It stays there. Sorry about that. I want to introduce two of our governing board members today. I think they're just two in the room here. Linda Oakes, a familiar face to you folks, and Renee Franklin, a new appointee to the governing board. And so they're here in support of our mission. And speaking of support of our mission, I will always say it, whether I'm here one more time or 10,000 more times, is we would not be a mental health center without you folks and support from the county and the taxpayers. So thank you for supporting our mission. So I want to just walk you through a few things this morning, and I'll probably just run through this report real quickly and then stand for questions. So, but my time is your time. We are provisionally certified now, have been since July 1, as a CCBHC, a Certified Community Behavioral Health Clinic. That doesn't change the fact that we're still a community mental health center, but it adds a layer of enhancement to services. Folks are getting in more quickly. Medicaid's paying at cost. We're doing more integrated care, that is whole person care, just a number of improvements going on. So programmatically, that's working out very, very well. We just had a site review for what would move us from provisional to, well, I don't want to use the word permanent because nothing's permanent, but move us from a provisional certificate to a regular certificate with KDADS. We think that site visit, which happened last month, went pretty well. So fingers are crossed. We'll let you know the results of that. We hope to get our regular certificate, sometime this spring. So hopeful for that. So service volume is increasing. We can see that. It's a little difficult to go back like 2, 3, or 4 years and look at any kind of a graph because we changed electronic medical records, and it's hard to compare apples to oranges. We've tried and had to take a lot of Excedrin trying to make that make sense. But overall, the data that we can look at, the manual data at least, indicates a pretty good increase in the volume of services. Something like 95 to 96% of people who walk in Monday through Friday, 8 to 5, with just a regular intake, not a crisis intake. We're seeing 95, 96% of those people, sometimes as high as 97% the same day. That is, they don't have to come back the next day. Yeah, I always tell people, be aware that if somebody comes in and they're in crisis, they get seen right away. The average time it takes them to get face-to-face with a therapist, once they fill out a couple papers, which is probably a couple more that we would like to have them fill out, is about 12, 13 minutes, and that's about 24 hours a day as well. So, but a person walks in and says, look, I've got some problems, I think I need some help, I'm not in a particular crisis. We see about 97, 94, it kind of ranges a little bit on the same day they walk in. People can also make appointments. If they've got work, they have to schedule an appointment. If they got a transportation problem, if they got child care issues, things like that, they can always schedule appointments for 10 o'clock on Thursday if they want to. So that's available to people. So if you hear of any access problems, please let us know. We think it's greatly increased. I want to brief you on or as much time as you like, on the topic of a one-stop shop. And I always add / reentry center. I will always go back and credit Director Cole. See him out there today. He's talked about the need to enhance the reentry work that we're doing when folks leave the jail. What can we do to wrap services around them? A lot of good work going on now at the jail regarding reentry. And sometimes, Brian and crew, they don't have a lot of, those folks over there don't have a lot of notice when somebody's leaving the jail. Sometimes they do. So one of the ideas that came up in his in the planning for a mental health facility at the jail was this idea of reentry. Since we have a number of folks there that have behavioral health problems, some of them come to jail who come from homelessness, that kind of thing. what can we do to enhance services on the way out that door? Can we wrap services around people, almost like a gauntlet of protective services? So that got me to thinking about anything we can do to work with the jail on reentry. So a lot of conversations going on about that. And that also led to a kind of revival of the concept of a one-stop shop where really anybody could go and get access to the services they need. So if a person is unsheltered, if they're new to town, they just don't know where else to go, they might need help with food or rent or childcare or mental health care or, just employment, housing vouchers, all that stuff. So we've got, there's a couple of conversations going on now about a one-stop shop, and that could also, of course, be available to people coming out of a county jail. But the idea of a one-stop is it's a place where you could go and actually get enrolled in services. So through the Mental Health Collaborative, which is a piece of Live Well, Shawnee County, which used to be called Heartland Healthy Neighborhoods, I'm facilitating the Mental Health Collaborative until somebody else wants to take it over. But one of the conversations that has popped up there is one-stop shop. So we've got several committees just working up information about what a one-stop would look like for the city and the county. So I would think, sometime spring, summer, fall, we'd have something to recommend to, any governing body or group or coalition that might want to take up the cause of a one-stop. So we just think it's a great way to, enhance access to care, reduce barriers, keep people from falling through the cracks, that kind of thing. It's a place where people could go and maybe get a city ID. Maybe it's a place people could go to learn more about, are there parenting classes out there? It'd just be a safe place. My vision of it is it's open Monday through Friday, 8 to 5, but it's actually a real place you could go. But it's not like an agency would set up a whole office and a whole set of programs there, but it would be that access. So you could come in, you could get enrolled, and actually become a client of X place, and then and walk out with an appointment and really get access to services in that way. So we're starting to talk pretty seriously about a one-stop, and we'll try to keep you guys informed on that, and would always defer to Director Cole. That's kind of the progenitor, where the seminal idea came from. So the other thing we formed a couple of years ago at Vallejo, a community coalition, we call it the Intersection Coalition, which refers as the intersection between behavioral health care, public behavioral health care, and criminal justice. So we've got probably 35, 40 people on that list, pretty good attendance, 18, 20, 25 people attend. These are some of the topics that we've been talking about, and of course, a one-stop is on there. Homelessness and housing, of course, is a huge conversation in the community right now that this group's actively involved in. Access, competency stand trial, just a number of things. So just want to post you on a couple things we're doing there, and then present the Vallejo fact sheet, and just submit that for your consideration. Stand for questions. Governing board members are here as well. If you have questions of them, we'd be glad to answer any. So.
Questions for Bill? Bill, as you see it right now, where are the major needs for Vallejo? Is it in additional crisis counseling? Is it more in housing assistance? Where are you seeing your biggest needs?
So the constant challenge we're going to have at Vallejo until Medicaid is expanded to include working people who just who don't qualify at the present time, is going to be the uninsured and the underinsured. And you hit it right on the nail head there, Commissioner, is that the demand for crisis care is pretty significant. People are struggling with housing, and so we've made, especially with the interagency groups that we've been working with, trying to make strides there. People are struggling with food insecurity, a number of things, but some of these things really revolve around personal and family crises that we're trying to respond to. But currently the number of uninsured individuals that we have is right at 30%, and so it's a constant challenge. Right back to the county's funding pays for that. Much of the state grant money that we get pays for care for the uninsured, but with price increases, staffing demand, and just the increase in demand, it's an area where we're going to continue to struggle.
So it's the people that come in crisis that don't have insurance that are falling through the gaps. that's where our main needs are?
Well, yeah, I want to say they're not falling through a mental health gap. I mean,
Right.
those, a lot of, services right there. I like to think nobody's falling through that crack. But yeah, if we need help anywhere, it's with crisis care, particularly the 24-hour work we do with the residents, and the folks that we put out on the street, to work with people who are homeless, maybe people who are underhoused. The home-based work that we do and the employer-based work that we do with people who have a long-term mental illness and supporting them through case management, crisis care. We have a crisis case management team that, is available at all hours of the day. Funding those positions through Medicaid has become a whole lot easier now that Medicaid pays that cost. But again, a large number of those individuals that get those specialty services, including crisis care, which is a big demand area for us. You're correct about that. The number of those individuals who are uninsured hits us pretty hard. So again, the county's funding, the state's funding, that all goes toward the uninsured.
Okay. Employment, recruitment, are you still having difficulty getting employees and keeping employees? I know for a while, there was always the opportunity for employees to go get higher salaries in other industries.
Yeah. I think we're competing pretty well. The governing board is into about a 2-year campaign to raise salaries. We added a holiday or two and increased benefits and, some referral bonuses and longevity bonuses and some things like that. Hiking pay has been a big one. And I think we've moved everybody up to at least $15 an hour. Of course, that was kind of the standard a year and a half ago. Probably looks more like 17 or 18 now. So, but everybody's at least $15 an hour for those starting paraprofessional kind of positions in our crisis center, our detox program, things like that. We've had to hike the pay for our prescribers, therapists, and really everybody all up and down the board. It's been a pretty expensive proposition. And so I believe about this time last year we had something like 68 openings and about the same number of budgeted positions, about. And I think today we're at about 30 or 32 openings. So we've cut that in half. I'm gonna say our vacancy rate is right around 10%. I figure that based on if we were fully staffed and we had 0 openings, we would employ 350 individuals, full-time, part-time. And so with about 30 or 35 openings, I calculate that vacancy rate to be about 10%. It was 16, 17, 18% a year and a half ago. So big strides forward, but it's been an expensive proposition, like for all employers. But yeah, made a lot of, I'd say we've, covered half that territory. I'd like to see it at 0. I think there'll probably always be 10, 12, 15 openings at Vallejo, just because of turnover, maybe a new position, somebody gets a promotion, that kind of thing. So,
Is fentanyl still having a major impact in Shawnee County?
fentanyl's an issue, and if it's not a bad enough problem, just identifying the drug is one thing, but we're starting to see it, laced in lots of other things that people might use. But yeah, it's an ongoing problem. The opioid, and is a big area of concern, but also the methamphetamine, epidemic crisis is a problem that we're trying to work with partners to provide the treatment that people need. So yeah, it's a driver of a lot of concerns that we have.
Okay. The questions?
Health department's been good. They provide us with Narcan and some other things, other agencies as well. It's good stuff to have around. It's just a part of the arsenal for any kind of first responder, including mental health staff. But good question,
You
Commissioner.
mentioned Medicaid, Medicare, they pay for a lot of services.
They do. So we're the Medicaid is to us what Medicare is to a hospital. And so with the recent changes last summer where Medicaid pays a cost for counseling, case management, peer support, crisis care, we're seeing the effect of that. Mainly what it's doing is resulting in quicker and more integrated care for people. But yeah.
You guys do pre-admission screening for some psychiatric facilities. How does that?
We do. So 24 hours a day, we're on call for lots of things. We have a therapist on call in the building 24 hours a day, and other support staff and security. So if someone is experiencing an acute mental illness, an exacerbation of bipolar disease or schizophrenia or something like that, And their mental illness creates a situation where they are a harm to themselves or likely to be, or to somebody else. Then we screen them. It's a formal process. It's based in law. I think it's Chapter 59, where a mental health center, is bound by law to interview somebody. Sometimes people come in on their own or with family, or they come in, for the referral from the hospitals. Sometimes brought in by law enforcement, other first responders. We conduct screening. If it looks like that screening indicates that a person needs involuntary care, and of course, we always offer voluntary care first, either at our crisis center, Stormont Vale, or other places. If a person refuses voluntary care and they have a severe mental illness, they're likely to be dangerous to self or others, and they're unable to participate in their own treatment design or process, then we can ask the DA's office to petition the court for what's called an OPC, an order of protective custody, on mental evaluation. A hearing occurs, the judge will find probable cause that the person needs to be placed in a psychiatric hospital. Sometimes they are, sometimes they aren't. And then if they are, then we follow that individual. They stay at Osawatomie for 10 days at least, maybe sometimes a few weeks, a couple, 3 months, but we have staff that go to Osawatomie all the time and coordinate with people and work with folks to try to get them back home, get them back up on their feet. But yeah, there is a legal and approved clinical process for evaluating people at all hours of the day. Now, fortunately, most people don't come into care that way. They come in through the voluntary door. So we always try to, make sure that door is open wide and people can get in easily. So, but we are available and do screenings, pretty regularly.
So Bill, just kind of out of curiosity, like if somebody comes into your facility and they have schizophrenia and you guys treat them and get them back on some meds, when they walk out the door, do you guys send them with like a 90 days worth of whatever medicine they need, or what happens once they leave your facility?
That depends on the individual, and that's a great question. That depends on the diagnosis and the individual, and how independent and capable they are of managing their own medications. And we try to be pretty careful sending people out the door with medication if they're any kind of risk to themselves. So pretty limited there. We administer right at 300 or so intramuscular injections of antipsychotic medications voluntarily. People come in once a month, every other month. They get their antipsychotic shot. Helps control the mental illness process. Pretty much miracle drugs. Many of them don't have to take a pill every day, and so it's easy to get up to medication compliance. We do a lot of that. There probably isn't an exact standard for, we only give 30-day scripts or 60 or 90. We do have people that only come and see us once a quarter. They're pretty stable. Their recovery's at a great place. Here's your script for 90 days, come back. Other people, in fact, we have a program where we're taking medications twice a day, every day, to about 60 people or so who are a little bit fragile in their recovery, who need some extra support, people we don't want to give, 10, 15, 30, 40 days worth of medication. We'll actually take it bagged up by the pharmacy, take it to the individual, and we don't administer those meds, but we are there to make sure they get it and that kind of thing. So there's probably not a standard. People who are pretty stable in their recovery are coming in to see their prescriber 3 or 4 times a year. People who need more, maybe they're just coming out of the hospital, maybe need a little more time. We'll see them, once a month or as need be for medication. So also same kinds of thing fits with other services. Some people we see, 3 or 4 or 5 times a week. Other people only maybe need to come in once a month and do a check-in with their therapist or a case manager. Just depends on how their recovery is going. Of course, the nature of mental illness is that could change. Somebody do real well for months or even years, and then like with a lot of diseases, they'll hit a setback for a while. We're there to start filling with volume and additional services to get them kind of over that hump back to recovery. But that's also a great question.
So you mentioned there's like a shot that you can give that's good for like a month, or
Yeah,
like
sometimes longer.
And that's pretty effective with folks?
Very.
Or
Yeah, very.
how many, like is that readily available, or, I mean, I've never even heard of that, but, I mean,
Yeah.
how much does something like that cost?
Well, I don't know, but I could sure have our medical director come and talk to you about that sometime. There are a number, in fact, the injectable antipsychotics have been around for a long time, Haldol and Prolix and some of the older drugs that they use. Some of the new antipsychotic drugs they have, are greatly more effective on the primary symptoms called the main effect, and they have fewer side effects. But a lot of folks can get by with an injection once a month. Some have to supplement with, maybe they take an antidepressant medication along with that by pill form or an anti-anxiety medication. But so there are just some miracle drugs out there. I probably couldn't stand here and give you a list of them.
Sure.
Or what they cost, but our pharmacy, Genoa, stores those and makes those available to our prescribers who are like right around the hallway from the pharmacy. Then they can stop on the way out the door and check in at the pharmacy and get what else they may need. So it's the best answer I can give you standing here, not being a prescriber. The cost can be expensive. I don't know what that is. Medicaid pays for some of that. Commercial health care, Medicare will pay for some of that. Where an individual cannot pay for their psychiatric meds, sometimes our pharmacy will help out with that. Genoa will help out with that. Some of the actual pharmaceutical companies have programs people can get on to help with their medication. So you can take something that costs X amount and get it reduced down to this. We do have a client emergency fund that we maintain for people that really need a med and can't afford it. We can help with that to some degree. The state of Kansas also has a prescription drug program that's available. It's usually a finite amount of money, but we do have access to that as well. So there are 3 or 4 or 5 routes a person can get there. I would hate to think anybody walks out of there and can't get their script filled, particularly if it's something that keeps them out of the hospital, keeps them going to work every day, keeps them balanced, allows them to lead the same kind of life that you and I lead, or at least, opportunity for that. So
Yeah, and that's sort of what I was getting at.
Yeah,
I mean, it's that, the accessibility of that. I mean,
yeah.
Like you said, you don't want to give a 30-day supply of pills to somebody walking out the
Right.
door where they might just go
Hurt
take them
themselves.
all, or
Yeah, that's right.
throw them in the trash can or whatever.
That's right.
But, if there's something available that, would
Well,
help.
and that's the beauty of having a continuum of care in one house, so to speak, is that we can have a peer support worker check on that individual 2 days after they leave the prescriber's office. We can have a case manager go in there the next day and help them, organize their affairs, maybe prepare to go to work, that kind of thing. They see a therapist once a week, a couple times a month, a licensed person. So they've got a team of people that, now we have quite a few people who only get medication. They only come in 3 or 4 or 5 times a year, but they're at a point with their recovery, they don't need those other services. So, we fill those slots with people who are more acute and assigned to the provider. We don't wrap services around people, and it's been a pretty effective model for many, many years with Community Mental Health Center. So, these injectables are miracle drugs. It's one of the reasons that we can treat people at home, and people don't have to be in an institution. If they do, they may be at state hospital for a few days or a few weeks. Stormont Vail does a great job of helping maintain people on medication as well through their outpatient practice and their inpatient practice. So it's a pretty great effort. I'd be pretty unhappy if somebody didn't get their medicine that they really needed. And
Right.
If you hear of anything like that, please let me know. But I'm assured that people that need help are getting help, and we're giving several hundred of those injections every month. So.
Bill, Shawnee County received monies as part of an opioid settlement, and we have yet to designate where those monies would go. I know there's been some preliminary discussions between your agency and other mental health
Correct.
providers in Shawnee County. The county will have to look at how that opioid settlement in money is utilized. I know last year in our budget, we budgeted $2,250,000 thereabouts, and whether or not that is used to offset the subsidy, if it goes to some sort of other programming. But if you were to receive the opioid settlement money, what were some of the things Vallejo would want to do with that?
I should have brought the proposal with you. Counselor Eckert has a copy of it. Jennifer's got a copy, and I think I may have passed one to you guys earlier. But Vallejo formed a coalition with Family Service and Guidance Center in Pars, Topeka, I don't know, a year or so ago-ish. Came up with kind of an a la carte menu of services that the county and the city, if they choose to, could fund with those opioid dollars that would be run by the partnership. And so we came up with things like, some testing supplies, you could, training for staff, officers, increased access to a residential bed. It's what we call an inpatient 28-day bed, crisis services for kids. So what we did was we took, at the time, from the former Attorney General's office, there was a paper that was published that listed all the appropriate and approved expenditures that an entity, a city, county, state, could use those opioid dollars for. It's a pretty extensive list. And so from that list, we researched out, okay, what are the gaps in care in the city and the county? What would help people in their recovery? Programs that Vallejo Family Service or PARS could operate. Access to education for parents, maybe seminars, things like that. The production of educational materials on, fentanyl, opioids, substance abuse, marijuana, all that kind of stuff. So those are one-time dollars. So we tried to design services or programs or initiatives that this money could be used to kickstart, so that we wouldn't be dependent on all those dollars year after year after year we fund it. And so there's a sustainability plan with each of those, and we tried to attach some budget figures to that. It's a little difficult to nail that down exactly, but at whatever point the commission would entertain a formal proposal, we'll come back and make that proposal to you, and want to have more time with the counselor to look through that. And so
Okay. Bill?
to anybody else who wants to answer that question, but we're ready to put those dollars to use at whatever point the commission wants to use some or all those dollars in that direction. We think we could present you with a plan that would be acceptable, per the parameters of the law. So.
Bill, I have one other question here. I noticed your total services from December 2022 to 23 went up 18.5%.
Correct.
Crisis intervention went up 49%. Detox services 182%. What's driving that? It's just, those are tremendous increases.
Yeah, it is. So we don't know. I mean, the demand from people who are unsheltered or people who don't have permanent housing. I think the economy is driving some of that. People are struggling. People who live on fixed incomes, disability or Social Security or maybe a pension. Those dollars don't tend to increase as the prices have gone up. Wages have gone up, but some of those subsidies have not gone up. I think just the general pressures that society is feeling, and we've tried to make ourselves available to people. So part of it is you build it, they'll come. If you don't, they won't, or they'll be there and they'll be unserved. We won't know what the problem is. So being more accessible to people is part of that. But I just think that, the number of people who are struggling and trying to adjust has brought more people to seek crisis care and other kinds of services. So we try to get the word out all we can. I don't know there's one singular cause, but the stories that we're hearing from people are more acute and more desperate, and so we just kind of the pinch that society's in right now in terms of social and health problems. But there's more awareness, so people are aware that, oh gosh, I have a problem, they're more likely to come in, particularly if the doors are wide open. So I don't know if I have a really good, solid answer on some of that. I think the detox, maybe that third bullet there on the middle of the first page, some of that would be driven by the opioid crisis and the methamphetamine crisis that our community faces, that trying to give people an opportunity to recover, make ourselves available to them.
Other questions? Bill, any other thoughts or?
Well, I can't say thank you enough, though, folks, for the support that we get, and we wouldn't be here without you, so thank you.
Thank you, Bill.
You bet.
All right. Our next item is public comment. If there is any member of the public that wants to comment. Morning, Henry.
How are you all? Cheers. Reader's Digest version of the MPO was originally, now it's called the MTPO. MPO was formed after Eisenhower basically did the Interstate Act and was throwing all these federal funds in interstates across America. Governor Robert Docking decided that planning commissions that were made up of the city and county could be the MPO. In about 2001, Joan Wagnon appointed me to the Metropolitan Planning Commission, and we were then the MPO. We were the first MPO to ever have public involvement, where we actually met the federal guidelines that is required to get the federal funds in the community. We were also the first ones to notice that the county had not been complying with the requirement to submit a capital improvement program. So the idea was, when you had a metropolitan planning organization, MPO, that you'd look at the CIP of the county, you'd look at the CIP of the city, and then you'd have public involvement, and the community then would actually pick where the federal funds would go. You'd engage the public. It's a novel idea of getting the public involved in the decision-making process, but I thought it was a good thing. So I actually met with the guy that ran the federal highway, and he laughed at me for thinking that I was ambitious enough to change how we did things. And we gave it every effort we could. And there were a lot of the planning commissioners and MPO members, which is all the same, that felt the same way. It was amazing to have a consensus that, you know, that we do need to change how we do things. Well, it wasn't very long after that we were disbanded. You know, hey, don't you dare try to change how we're doing things, because it's back to how impossible it is to introduce a new idea. And it was a shame that the governing bodies between the county and the city decided to disband the organization. Because I'll tell you, you ought to talk to my friend David Banks, who just ran for city council. He said one of the main things that he said is that, you know, I think the planning commissions actually worked better when they were together. And not having the city involved in the, out in the 3-mile radius is very important. But what I'm getting at today is we really need to focus on the MTPO, because a friend of mine told me, he said, I don't think they've even met in 3 years in person. And I, quite frankly, can't remember even the last time they had public involvement. And so why do I bring up this whole epistle today, or my sermon today, is because we need, if we want to bring back the boulevard, well, let's don't put all the burden on the developers. Let's do it. Let's bring back the boulevard, but let's engage the MTPO. Let's engage the MTPO to take a look at the boulevard. And let's say, well, look, we've got a certain amount of federal funds, and we're gonna make an investment in the boulevard. Let's get way ahead of the situation. Instead of reacting every time a guy comes in with a plan and, hey, we got our hooks in you now, and now renovate my city. Because that's basically what it's like to be a developer in this town. You've got to beg for your porridge. And it's getting harder and harder. And actually, it's just getting to where it's just not worth it. I literally had to tell a client for the first time, you know, I don't think this is a place for your capital today. Let's wait. Let's see how things go. Because I have a certain obligation to get a return on the investment for my clients. Because, like, you can't be in the position of, like, well, why didn't you tell me? And that's kind of what this is nice about being able to come here and have a little public comment, because the genesis of where we got, how we got here is important. We learn from our mistakes. Unfortunately, it feels like in our community, we don't do anything about it ever. And creating a more engaged MTPO today and getting public involvement of where these federal funds go, it's equally as important of the drum I've been beating of taking away $3.5 million in overhead to actually start putting money into infrastructure. But let's engage the public. Let's engage the public today of where these federal funds should go. If we want to bring back the boulevard, let's do it all together. Don't put the burden on the developer deal by deal. We've got a lot of work to do out there. I'm telling you, it was a good idea to tear down that hotel, and we should have done it. You know, sometimes opportunity knocks but once. But we have a big task ahead of us in a very blighted area, the White Lakes Mall, and how it got there today. Today, it's not our fault, but it's our way of fixing it. And I'm telling you something, working on a property just down the street from White Lakes has made my job impossible. You know, I could never make a deal on that old Bennigan's because you're standing there and you see White Lakes just running down. So think about the MTPO, think about those federal dollars, because that's all I'm going to start doing now too. And I appreciate your time. Thank you.
Thank you. Any other public comment?
Good morning, Commissioners. Linda Oakes. I have the pleasure of serving on Vallejo's board. Bill didn't mention, because I think he's pretty modest, is how much hard work he and the Vallejo staff put in on the warming centers during the extreme weather. And we've talked about extreme weather as a board quite a bit and how that's just going to keep happening. And so we need to be prepared. So I just want to thank him and recognize him. Those warming centers save lives. And churches stepped up and opened warming centers. It was a great community effort. So, but I think we're just going to have to plan on more of that in the future. So that's all.
I agree. I think that when it comes to warming centers and cooling centers, planning for cooling centers should be going on now,
Right.
not in May.
Correct.
Warming centers should be discussed in July, not in December, so that we have our plans well in advance. And so, I mean, the seasons, we should have some predictability that we know that it's going to be cold in winter and hot in summer.
Yes, and I think it takes everyone, city, county, all the rescue mission, Vallejo, everyone that worked together.
Right.
I mean, I remember a heat index last summer of 138, so we know we're going to have it again.
Right.
So I just wanted to thank Bill and his staff for all their hard work at that.
Yeah. What we didn't anticipate was a boil advisory at the
Right.
exact same time.
Yes.
It's all public health, folks.
Thank you, Linda. Any other public comment? Any administrative communications?
Good morning, Jake Henry, Shawnee County Emergency Management. Just want to remind everybody that this is Severe Weather Preparedness Week. We have the Storm Spotter class tonight at 7 p.m., Washburn University Student Memorial Union. And then Wednesday, we have the statewide tornado drill at 11 a.m.
Okay, appreciate it. Thank you.
Thank you.
Any other administrative communications? Commissioner Mays?
No, big thanks to all the fire departments and the Red Cross and our emergency management folks for all the work they did on the fire up north yesterday. I know people worked long hours, and there were volunteers out there helping out, and so always good to see that. Appreciate all your hard work.
Great. Commissioner Rippon?
I want to echo those comments, and I drove out there and I saw a plane helping out with, where does that plane go? Are these spray pilots, or who are these guys that, do you know?
Are you asking me?
Yes.
You want me to come up there?
No, it doesn't matter.
You want me to just dial off?
Yeah, that'd be fine.
So when that kind of thing happens, you have the county do the declaration, as you're all aware. And then once we contact the state, they have a pool of assets that they can use. Some of the aircraft, KHP has aircraft. There's a variety of different agencies that we can pull from depending on what the type of mission is. As really built more on what's the mission and the assignment type of area, so.
Are they spraying water, or is this some kind of fire retardant, or, you know, what they?
I'm not 100%
Okay.
sure on that.
I think Heinen Brothers out at Billard, I think, provides a lot of that.
Okay.
And then National Guard, I think, helps with some of it too.
Yeah, when you start seeing the like the UH-60 helicopters with the Bambi buckets, obviously that's Guard. But we try to fill those missions with the Guard being a later option just because of the cost. The cost of running those is so expensive per hour.
Well, it was fascinating to watch them, anyway.
A lot of cooperation, a lot of coordination, and I want to thank our team for all that they did and all the people coming together. When we're addressing a fire, over 2,000 acres, I believe, is kind of the rough estimate of the scope of the amount of area that was affected. So it's a big swath of area to try to coordinate, so.
And
Thank-
no structures lost, right?
No structures lost.
Yeah, to the best of my knowledge, we didn't lose any structures, and like mentioned, the Red Cross was very helpful as well, bringing out
We-
meals for first responders who've been out there working on the yards.
And we didn't lose any livestock that you know of, and,
Not that I'm aware of.
Okay.
very good.
All right. Well, I don't know that I have anything additional, so we are adjourned.